So thank you very much for inviting me, Dr. Cottrell. So my name is William. I'm a rehab physician at Modbury Hospital in Adelaide. And today I'll be presenting to you about burns rehabilitation. So just to tell you a bit about Adelaide, so it's about a 1.3 million population. Work at Modbury Hospital. We have 52 inpatient rehab beds, and we service about 400,000 people in the northern catchment of our city. And my interests are including stroke rehabilitation, spasticity management, and return to driving assessments. So a lot of the data information that you'll see today is from the Agency of Clinical Innovation, which is from the Australian, or I should say New South Wales guidelines for a lot of our rehabilitation. But what I'll be talking to you will be the acute management of burns, followed by the subacute and long-term management, which includes managing complications, pain, edema, therapy, compression, and also psychosocial issues. So from the acute management perspective, I think it's important to recognize the Jackson's model of burn. So when a patient sustains a burn, there's an area where there's irreversible tissue loss. There is a zone of stasis surrounding the area, which is a salvageable area. And depending on the past medical history, how quickly administer first aid, provide fluid resuscitation and general resuscitation, that area could potentially be saved. So in terms of first aid, we try to stop the burning process. We cool the wound. We run the wound under a running cold tap for about 20 minutes and up to 2 hours for chemical burns. It's important to avoid any ice that might cause vasoconstriction, hypothermia, and itself can also cause burns. And it's important to remove any constrictive clothing or jewelry at this time. Part of your emergency assessments, this is your usual primary survey going through A, B, C, D. So airway, it's important to ensure the airway is maintained, and they may or may not need a cervical spinal control. It's important to look at the breathing, monitor chest inspections. With burns, it's important to note there may be a need for escharotomy if there is a full thickness burns around the whole chest. And also you need to consider carbon monoxide poisoning as well. In terms of circulation, it's important to monitor peripheral pulses and stop any acute bleeding. Part of your management and assessment of burns involves capillary blanching testing. So that's looking at central and peripheral sites, burnt and non-burnt areas. So any longer capillary refill could suggest hypotension, hypovolemia, or a potential need for escharotomy. Part of disability assessment, we look at alertness, response to voice, painful response and unresponsiveness, and you also look at pupils and other potential causes of reduced drowsiness as well. Part of your exposure, you want to remove any clothing or jewelry, keep the patient warm, do a log roll if required, and start looking at what area of the body is burnt. I'll touch briefly on nutrition and feeding. This is part of the early assessment and management. You want to try and optimize this as much as possible within the first 24 to 48 hours. After a burn, especially when there's a large burn, the body will go through a hypermetabolic phase, which can last up to 3 weeks. The Toronto formula for feeding is provided here. You may use different types formulas. However, it's not something to note as we also don't want to overfeed. Excessive carbohydrate feeding can increase oxygen production, can cause hypoglycemia and fatty liver. The overfeeding of protein can result in uremia, dehydration, and metabolic acidosis. And overfeeding fats can cause hypertriglyceridemia as well as compromised immunity. On the right side of the table, just some general points of what you want to try to aim for in terms of your protein, carbohydrate, and fat intake. I'll go through your fluids intake, but we use the Parkland formula for that. There's no specific requirements for macronutrient supplementation, but we know that to promote wound healing, you might want to consider zinc, vitamin A, and vitamin C. But also to note that we don't want to give them excess amounts of macronutrients, which can affect other vitamins and minerals as well. If patients are unable to tolerate enteral feeds, then you might need to consider parenteral feeds, such as TPN. So intensive care university in ICU might be required. So part of fluid resuscitation, this should be considered when there are burns of 20% in adults and more than 10% in children. So we use the rules of nines. So 9's for the limbs, upper limbs, 18 for lower limbs, and 18 for the front and back, and 9% for the head, and 1% for the palmar region of hands and fingers. So this is the modified Parkland formula of using Hartmann syndrome to calculate how much fluid resuscitation is required. When we look at the depth of burns, so just looking at general skin layers, we've got the epidermis, dermis, subcutaneous, and muscle layers, but we can divide these into epidermal, superficial, mid, or deep dermal, and full thickness burns. So it's really important to make assessments to determine the level of burns. So when we look at the color, we assess initially if it's a more superficial, it's more red. When you become full thickness, it becomes a white or brown or black charred color. Blisters tend to occur in the superficial to mid and deep layers. Capillary refill will progressively get worse the deeper the burn. As expected, you note that the healing will tend to improve for a more superficial burn versus deep or full thickness burn when grafting is required. And the deeper the burn, the more likely it is for a person to scar. So I'll go through the general principles of burn wound healing. In order to, so these include promoting wound healing and to ease discomfort. We want to ensure there's adequate perfusion in the person to minimize bacterial contamination, to minimize the negative effects of inflammation, to provide optimal wound management, ensure they have adequate nutrition, promote re-epithelialization, and also provide pressure management as well. These are the principles of burn wound management. That includes cleansing, debridement, providing appropriate dressings, and also managing the edema and also effects of scarring through pressure garments. So I'll go through the dressings, grafts, and also general scar management. This is from the ACI. It's just a decision-making tree on what type of dressing is required depending on the level of burns. So really important early on when the patient sustained a burn in the acute phase is about cleaning and debriding the burned wound. Pain management is really important. Without adequate pain management, the debridement can be quite painful, and sometimes this needs to be done in theatre as well. So we talk about cleansing the area, so removing devitalized tissue, exudate old dressings and creams, washing with a soft cloth or sterile hand towels in diluted solution, saline or diluted chlorhex, and also ensuring the wound is dry. Debridement, it's important to examine the patient and assess whether the patient needs debridement or not, and to remove any potential blisters. It's also important to note that in the early phase of burns, there tends to be a high exudate state. So it's important to monitor this and adjust this accordingly in terms of your dressings. And I think what we do here quite often is we like to use digital photography to monitor any types of wounds so we can hand over what they look from a day-to-day perspective to other healthcare members as well. So these are just some of the general dressing options that might be available, which can include silicone dressing, hydrochloride, zinc, silver. It really also depends on the type of burns they sustained. And in terms of the dressings, this will vary from place to place as well. So just going to show you some pictures of problem dressings. So we want to ensure that the patient, there's enough pressure to reduce edema, but we don't want to cause so much that it reduces peripheral blood supply, as shown here. We don't want it to overextend and cover joints to prevent them from actively moved. We also don't want them to be too loose where the dressings fall off too quickly. We don't want the dressings to fall off and expose the underlying wound. And we don't want a dry dressing or a dressing that will stick to the wound and cause a shearing effect when you change it. And it's also important to look at the surrounding skin. If there's macerated skin, we only want to target the area where it's actually affected. So in terms of skin grafts, early excision grafting improves mortality. Studies have shown that mortality difference ranges from 45% to 9% when full thickness burns are excised and grafted in 3 days compared to delaying grafting after 21 days. There's different options in terms of grafting. So this can be autograft, allograft, or using a skin substitute. Autograft is using the person's own skin. So there are different options. Full thickness skin grafts, they're great in providing cosmetic appearances and best over joints, but they're also less likely to contract and scar, but they have a higher failure rate. Split thickness skin grafts are better for covering extensive burns. However, there's also two types. So the mesh grafting allows you to provide the mesh pattern, stretch the skin further, but will more likely to have a worse cosmetic outcome and cause scarring. The sheet grafting, less scarring, allows better range of movements of the affected joints and better cosmetic outcomes, but more likely to develop seromas or hematomas, which can threaten the graft viability. Allograft and xenograft, so that's using other people's skin or using animals. This will need to be looked at and respectfully look at the patient's traditions and wishes, as that may or may not be appropriate for a particular population. Bioengineered synthetic skin can also be expensive. For places where they may not have skin grafting present or available immediately, amnion collagen sheets can be used temporarily to close the area before a living autograft or allograft can be identified. So we'll move on to management, subacute to longer term management of burn complications. So these are just general complications. So I'll go through this just on this slide and focus more on the principles of therapy to try and prevent a lot of these complications if possible. So infection, poor healing of failure grafts can occur, especially when the patient has a large burn, when there's a total surface burn area is greater than 30%, there's an increased risk of developing caloric and nutritional needs. And with the higher stress response, there's more likely to have increased catecholamine activation, increased insulin resistance, and also potentially result in bone mineral density loss. Dysphagia is also quite common. This can be due to smoke inhalation injuries, intubation, and also neurological impairments. It's important to have ongoing swallowing assessments from speech pathology if it's possible. Peripheral neuropathies occur in about 10% of most major burns. Various types of neuropathies can occur, whether it's mononeuropathy, axonal injury from deep burns, and also critical illness polyneuropathies can occur if the patient's been bedbound in ICU for prolonged periods of time. So it's also important to note that if you're doing nerve conduction studies on patients with burns, your results may not be completely accurate. If you've got thickened skin or hypertrophic scarring, this can also reduce the amplitudes in a nerve conduction study. Heterotrophic ossification is also common in large burns. This is where extraskeletal bone develops in soft tissue, typically over the elbow and knee joints of the affected limb. Patients usually start to notice they've got suddenly reduced range of movement. You can look at using NSAIDs, bisphosphonates, and if severe enough, you might need surgery. So I'm just showing some images of burns complications. This is from the ACI guidelines. So at the top left, we've got hypertrophic scarring, contractures where it's significantly affecting the range of movement in the ankle joint, axilla, and also elbow. Hand contractures and also knee contractures can occur if there's a reduced range of movement. So I want to emphasize this first point, which I think is one of the most important points in managing burn patients, is looking at the psychosocial impact. It can't be underestimated. Burns therapy, rehabilitation, management, and intervention can last for 12 months to 18 months. So it's really important to address these as they come along to ensure that patients do engage and are able to participate as much as possible. So for depression, that can occur to 20 to 61% the first year of patients with burns, 30% of PTSD as a prevalence rate, general anxiety is 13 to 47%. There tends to be a body image dissatisfaction. When patients do leave the hospital and return to living in the community, there will probably be change in their roles, and this may significantly impact the return to work. Sexual issues also a big issue that we need to discuss. It's a combination of both psychological, altered skin sensitivity, the effects from potentially burns, as well as from pain and medication side effects that needs to be considered. In terms of scar formation, this tends to occur due to deficiencies in the biosynthetic and tissue degradation pathway during the wound healing. It's due to fibroblast proliferation, and scars tend to occur after skin grafting, and it can cause significant depression, altered pigmentation, change in temperature tolerance, and pain. And there's an increased risk of developing scars if scars don't heal and it isn't complete within 21 days. So this is part of the scar management and burn therapy principles. We know that scarring can result in limitation in normal function, mobility, restriction of growth, and also psychological impact. Therapy should always start immediately and continue until scar mature, which is around 12 to 18 months. When mature scars are not active, they appear pale, soft, and flat. Burn skins and active scars contract over hours rather days or weeks. So it's really important that we try and optimize these management as soon as possible. So that includes edema management, exercise, splinting, looking at compression garments, skincare, and also procedure options as well. So from burn injuries, pain is a significant issue in terms of participation. And it's quite complex. It's not just a single type of pain, and it will vary from the acute phase to longer-term chronic pain, and can vary from neuropathic pain to hypersensitivity to vascular issues. I think it's really important that as we progress into longer-term pain control, we look at a biopsychosocial model in terms of optimizing the pain. So that's why, as I mentioned before, to look at if the patient's got depression, anxiety, or PTSD to look into that as well, because that itself can also contribute to the pain. Opioid analgesics usually first line for moderate to severe acute pain, and NSAIDs, gabapentinoids such as pregabalin, gabapentin can be used. I also want to mention that pruritus that occurs in about 87% of adult burns and is a significant issue. Antihistamines are usually first line. However, once the scars are healed, topical steroid injections can be considered as well. Also, non-pharmacological management includes avoidance distraction techniques, guided imagery, hypnotic analgesia, as also virtual reality. It's important to provide them information and also practicing mindfulness, relaxation techniques, and also look at CBT as well. Edema. So when there's a large burn, when there's more than 20% of the total body surface area, there tends to be a systemic inflammatory response that can be due to impaired lymphatic system, and also immobility and inappropriate compression can lead to exacerbation of edema. So general principles, we look at positioning, elevation, and splinting. Compression will help reduce the edema. Exercise, active and passive, and asking patients to participate in ADL training, and also massage therapy. So with exercise, we like to maintain and regain range of movements, strengthen exercise tolerance and function. Exercise should begin as early as possible to range the affected limb, ambulate, and ask the patients to participate in ADLs. Exercise from acute until 12 to 18 months post-burn should continue. When there's burns over joints, it's important to maintain a range of movement and splinting to prevent any contractures to develop. We also should observe the stretching without clothes and dressings to see how much and what they're able to actually achieve, and it should be individualized when we provide that exercise. So I've just shown some images of tightness, contractures, banding, and the type of exercises. So stretches need to be low repetition, but long duration to provide a sustained stretch. It's also important that potential scarring and contracture with joints such as the face, neck, axilla, elbows, wrists, knees, ankles, and feet. So part of the exercise, ambulation, they should commence as soon as possible with the aim to progress to independent pre-morbid ambulation. Functional retraining, so we like to get patients involved in terms of managing their own personal ADLs and also IADLs if possible in rehabilitation. Only use adaptive aids if required, and we're trying to wean that off as soon as possible. And we'd like to get them back to the pre-morbid activities. And also we want to need to assess their driving. Strength-wise, we like to commence anti-gravity functional exercise. You can use the body as a resistance, use resistance bands, free weights, and also bed exercises. And part of the aerobic exercises, we can consider walking, cycling, and juggling. Precautions, considerations during therapy. Precautions are necessary with wounds. Careful hand placement and devices. We need to ensure that we don't shear the wounds when we provide the therapy. Some precautions, so exposed tendons, flaps, reconstruction areas, KYs. Medically, we need to ensure that their blood pressure can tolerate the therapy. There's no active infections, peripheral neuropathy, or wound breakdown. And we also need to think about the impact of sweat on the skin integrity that's still healing. Splinting and positioning. So the indication is dependent on the potential scar and the ability for the patient to maintain the range of movement exercise. Our aim is to immobilize the skin graft after surgery, protect vulnerable structures, prevent skin tendon contractures, and maintain joint range of movement. So this is what, at the bottom, what we're trying to aim, and this is what we're trying to avoid at the top. Splinting, the regime is determined by as how much the patient can maximum range with active exercise. After skin graft procedure, splints may remain on until the graft is stable and reduce the nighttime wear. Splinting can be via different options, include plaster of Paris or using thermoplastics. If a joint is losing range, it might be worth considering serial casting. For compressions, its aim is to prevent raised scars. So it's hypothesized that compression reduces excessive blood flow and delivery scarring mediators. Can be done in a variety of different ways: cohesive, flexible bandaging, tubular, elastic stockings, bandaging, pressure garments. But the aim is, and you also can use scar softening products underneath, with the aim of the pressure around 20 to 40 millimeters of mercury. So these are some of the options: cohesive bandage, tubular, elastic stockings, to pressure garments located here. So pressure garments, they should be worn at all times except for showering, bathing, massage, and moisturizing. They're worn while scar is active, so 12 to 18 months you can take. Patients need to be educated on how to don, doff, and to ensure that it remains clean. And they need to be assessed regularly every 3 to 6 months to ensure they provide the adequate pressure to prevent edema. Some precautions and considerations: they should be fitted correctly. They shouldn't constrict or cause wrinkles. Temporary seam line zippers is okay. Care needs to be done when donning and doffing to prevent tearing of skin. And contraindications might be when there's acute skin change as well. And as discussed before, really important that it's not too tight, too loose, or causing excessive distal swelling. Silicone pocket products can be used to soften red, raised, or hypertrophic scars. You can use sheets, liquids, or putties, and then gradually increase the wear time as tolerated, but continue to use until the scar matures. Massage, it's hypothesized to break up the collagen bundles that form scars, can help soften, desensitize skin, prevent adhesions, reduce pruritus, and also help with stretching. And at that point, later stage, when you provide massage, recommend moisturizing as well. Procedural options, so surgical scar revision. From a cosmetic perspective, corticosteroid injections can be used on heel epithelialized scars to reduce pain, pruritus, and reduce contractures. Botulinum toxin A injections can be injected to muscles underneath to relax muscle, reduce wound tension, improve wound healing, and minimize scar formation. Laser therapy, evidence still a bit on the lower side, but might help with ablating vessels, leading to tissue hypoxia, inhibiting excess collagen deposition. It may help with tissue remodeling as well as reduce use on atrophic and healed scars. Microsurgical flaps can be considered in hemodynamically stable patients without vascular disease. And skin tissue engineering is still an evolving field where we create a new living tissue to help replace human skin. So my take-home message is, so early intervention improves survivability. Early rehabilitation will reduce the long-term complications, and I can't emphasize enough of providing support and managing the psychosocial issues. These are my resources, and that's it.